Welcome everyone. Today I'm gonna present to you my PhD thesis, which is using personalized treatment to improve early resuscitation in septic patients. My name is Gábor Nagy. I'm working for the Semmelweis University Department of Emergency Medicine. My vision is each patient receives the care is that best for them. My mission is eliminate non-evidence-based data, improve survival in sepsis and septic shock. To achieve my mission and in service of better patient outcome and care, I have two projects, both of them started this fall. Let me talk about my first one, which is comparing the safety and effectiveness of personalized versus fixed volume fluid resuscitation in septic patients. Sepsis causes the death of more than 10 million patients every year. Fluid resuscitation is a cornerstone and fundamental in sepsis. Actual guidelines recommend a fixed volume of fluid resuscitation for septic patients. But however, in medicine, we know that one size doesn't fit all. This recommendation takes into consideration only one single factor, which is the patient's weight, and no further considerations on their comorbidity or actual condition. So, fluid resuscitation, as we know, is a double-edged sword. It can save lives by restoring hypoperfusion, but it can lead also fluid accumulation, which deteriorates the function of vital organs, especially the kidneys and the heart. Resuscitating based on personal physiological needs is thought to be safer. What is missing, the emergent role of physiology-based personalized fluid resuscitation is widely accepted, but the evidence on its efficacy is safety and limited. In the light of this, our aim is to investigate the effectiveness and safety of personalized fluid resuscitation compared to fixed volume or other non-personalized approaches. So our clinical question is personalized fluid resuscitation safer and more effective compared to fixed volume fluid strategy? To answer this question, we use the PICO framework. We are going to investigate septic patients. The interventional group's participants will receive a personalized fluid therapy based on the assessment of their fluid responsiveness. The comparator group are being treated with a fixed volume of fluid based on the current guidelines recommendation. The main outcome will be the 30 days mortality, and the secondary outcomes are organ support-free days, length of ICU stay, and SOFA score changes. We hypothesize that personalized therapy is associated with better outcomes compared to guideline-recommended fixed volume strategy in sepsis. The clinical implication will be personalized fluid therapy as a standard in sepsis to reduce the burden of sepsis and improve patients' outcome in this field. We conduct a systematic search in 3 databases with this search key where domain 1 refers to the population and domain 2 covers the intervention. We got more than 9,000 results. After duplicate removal, we still got a bit more than 7,000. And after the title and abstract selection, we have more than 2,050 articles to go through into the full text selection part of the progress. So about my second project, which is investigating the effectiveness and safety of immediate vasopressor initiation in patients admitted to the emergency department with shock. We know that shock leads to organ dysfunction with the highest mortality rate through hypoperfusion. Hypotension is an alarming sign of hypoperfusion. It is supported by data from anesthesiology, where it was found that hypoperfusion, irrespective of its length, increases the risk of major adverse cardiac events and acute kidney injury. And as you see on the slide, The longer time spent in shock with the lowest MAB significantly increases mortality. To avoid all of them, fluids and vasopressors play a pivotal role in restoring circulation. Current guidelines recommend the fluid as first and vasopressor as a second-line treatment, but there are no clear recommendations on the time, which is a very crucial part of critical care of vasopressor initiation. Too late start can cause delayed restoration of hypotension, but the too early leads to unnecessary vasoconstriction, may also impair the perfusion. Our aim is to investigate the efficacy and safety of immediate vasopressor combined fluid therapy in patients admitted to the emergency department with shock. Our clinical question is the following: does immediate fluid and vasopressor initiation enhance shock reversal without causing harm in ED patients with shock? Our population is going to be patients in shock admitted to the ER. The intervention groups participant will receive immediate fluid and vasopressor initiation on the admission at the ER. And the control group will be treated with fluid resuscitation at the first step. And if they are proven fluid unresponsive, we supplement their therapy with vasopressor. Our main outcome will be the rate of persistent shock after 3 hours of resuscitation, and the secondary outcomes are 30 days mortality, ICU admission and length of stay, and SOFA score changes. In this study, shock will be defined as a circulatory failure with, when mean arterial pressure is under 65 millimeters of mercury and lactate level is higher than 2 millimoles per liter. So the clinical implication will be enhanced recovery from shock to improve outcomes and to figure out a better patient care and treatment in patients with shock. So to summarize, I have 2 projects. I would like to complete my first one till the next September and the second one by the November of 2026. And I want to close my presentation with a quote from Gandhi, which sounds like that: you must be the change you wish to see in the world. Thank you for your kind attention.
In your second project, it's about shock.
Yeah.
Would you like to precise what kind of shock? Are you talking about obstructive shock or hemorrhagic shock or hypovolemic shock as well? Because in those situations, volume therapy probably is not the first choice.
Okay, thank you for your questions. It is very relevant. The only exclusion criteria will be non-bleeding patients, so bleeding shock is excluded, but it is about undifferentiated shock. So in the first 30 minutes at the ER, we aren't able to decide which type of shock we have to deal with. So this is why it is a common thing, so it's defined as shock. And we don't know if it's obstructive or any other types of shock.
My question is related to the second project, because that would be, if you succeed, it's going to be a huge study and very important. Patient arrives in a septic shock or any kind of shock, and you want to initiate fluids and or vasopressors. But if you do a randomized study, then you need a consent form. Did you think about how long can you wait for the consent or find the relatives or anything?
It's a very hard question and a very important and relevant one. This study is in a very early phase and an early stage, and we didn't think over all of the details, how we can manage it, but it's have to take under consideration.
In the first study, you would like to assess the personalized fluid therapy.
Yeah.
So what are some ways that you can make this therapy personalized? How can you assess the need of the fluid of the patient? So
there are some ways. Some of them are easy, and some of them is it's a bit difficult. I think at the most common way to assess patients' fluid responsiveness in a very easy way. It is using an ultrasound tool. For example, measurement the IVC diameter during the respiratory circle, or define the stroke volume by ultrasound. I think it is the two more easy way to evaluate the response or to tailor the treatment of the patient.
What kind of fluid would you use? Would it be saline or would it be only crystalloids for the fluid resuscitation?
It is a good question, as it's still a debate whether saline or balanced solutions. I think balanced solutions will be used in this study.
Thank you.
In this case.
Thank you.
I prefer them.